Hi, everyone. In this section of the update, we will focus on prominent publications in the areas of extracorporeal support and pharmacology that hit the headlines during the past year. So we are all familiar with the extracorporeal membrane oxygenation technique that we use in patients with severe hypoxia, particularly with the COVID pandemic going on around the world. Some of our patients at least have been through ECMO, and some of them have indeed survived through it. However, this study addresses the question of extracorporeal carbon dioxide removal. So the REST trial asked the question, does extracorporeal carbon dioxide removal, or ECOR, combined with a lower tidal volume ventilation strategy, improve clinical outcomes in patients with acute hypoxemic respiratory failure? So that's the question that they asked. Ever since the ARDS-NET study was published nearly 20 years ago, we've been using restrictive tidal volumes of approximately 6 mils per kilogram, and also limiting plateau pressure to 30 centimeters of water as much as possible. While this strategy has been shown to be associated with improved survival in patients with severe ARDS, one of the problems is, of course, the hypercapnia that ensues in many patients. While hypercapnia may be, it's been shown to be fairly harmless, or perhaps not associated with as much harm as the ventilator-induced lung injury that you may cause with injurious modalities of ventilation, there is still some interest surrounding possible carbon dioxide removal through extracorporeal techniques. So that's how this study was conceived. There have been some observational studies in the past as well, which have shown that carbon dioxide can be removed effectively through the extracorporeal methodology. And this study was, in fact, the first randomized controlled study that asked the question, would this technique combined with a lower tidal volume ventilation, lower than 6 mils per kilogram, really lead to improved clinical outcomes among patients with ARDS? So this study was actually conducted in 51 centers in the UK. The inclusion criteria were a PF ratio of less than 150 and a PEEP level equal to or more than 5 centimeters of water. They excluded patients who were on ventilation for more than 7 days, patients who were late in the stage of ARDS. And they also excluded patients in whom the clinicians were able to reduce tidal volumes to less than 3 mils per kilogram. So what did they do? In the ECOR group, or the extracorporeal carbon dioxide removal group, in which there were 200 patients, they anticoagulated them systemically, which of course is one of the most important requirements for ECOR. You need to anticoagulate them. They used a lower tidal volume, or they aimed to use approximately 3 mils per kilogram in the ECOR arm. The flow on the ECOR support was 350 to 450 mils per minute, with a sweep gas flow of 10 liters per minute. And they maintained the ECOR support for a period of at least 48 hours and for a maximum of 7 days. So that was the ECOR protocol. And in the control group, in which they had roughly the same number of patients, 205 patients, they used a conventional ARDS-NET protocol of 6 mils per kilogram, plateau pressures of 30 centimeters of water. Both groups of patients received neuromuscular blockade as appropriate, prone ventilation as deemed appropriate by the treating clinicians. ECMO was resorted to as per the UK protocols if the need arose. So that was roughly the intervention and the control arms and the way they handle patients in both these arms. The baseline characteristics of these patients were very similar, not statistically significantly different between the two groups. At baseline, the median tidal volume was 6.3 versus 6.4. The PEEP level was 10 centimeters of water. The PCO2 level was similar, 53 versus 54. pH was similar. 11% of patients were prone in both the arms. The use of neuromuscular blockade was also similar. The median age, presence of ARDS at baseline, SOFA, Apache 2 scores, the PF ratios, and the driving pressures were all pretty much similar at baseline in the E-core group and the control groups. So the endpoint that they looked at as the primary endpoint was the 90-day mortality. The 90-day mortality was 41.5% in the E-core arm and 39.5% in the control arm. This difference was not statistically significant. And the Kaplan-Meier curve also shows at different intervals of time, the curves are very close to overlapping with each other, which essentially reflects the fact that there was no real difference in terms of mortality between the E-core and the control arms. And they adjusted for age, SOFA score, and the baseline PF ratios as well. And even after adjusting, there was no difference in the 90-day mortality. The tidal volumes in the E-core group, in which they aim to use a tidal volume of 3 mils per kilogram, was 4.5 mils per kilogram compared to 6.5 mils in the conventional arm. The ventilator-free days at day 28 was in fact lower with E-core compared to control or conventional ventilation. So it essentially means patients who are on E-core spent a longer period of time on ventilator. The 28-day mortality, ICU length of stay or hospital length of stay, which are other secondary endpoints, were also not different between the two groups. With E-core, the driving pressures could be brought down compared to the control group. And patients who had E-core were also prone less compared to the control arm. Adverse events were higher in the E-core group. So this study essentially showed that extracorporeal carbon dioxide removal does not result in improved 90-day survival. And in fact, there was some signal, as in one of the secondary outcomes, that the ventilation-free days may be lower with E-core. There were, of course, several weaknesses in the study, being the first randomized controlled trial to address this question. They excluded a large number of patients. Only 6% of patients who were actually screened were included in the study. And most of these units were using E-core for the first time or very early in their experience, and that may have affected the final outcome. The incidence of proning was roughly 10 to 11% in both the groups, which again, one would argue is lower than what one would expect in patients who are so hypoxic with a PF ratio of less than 150. The pH levels were lower and the PCO2 levels are actually higher in the E-core arm because of the low tidal volumes that they used. Roughly 3 mils per kilogram is what they aimed for, ended up with 4.5, but it was still lower, and that led to higher PCO2 levels and lower pH levels. So that again may have complicated or biased the final results. So the bottom line of this paper is that we need to wait before we embark upon extracorporeal carbon dioxide removal. We need larger studies, multicentric studies, and studies in centers with more experience before we can come up with real answers to this question. We are going through one of the worst pandemics in history, and in the last few weeks, Omicron has sowed the seeds of disaster across the country and across the globe. And one of the problems with the Omicron variant is that the conventional monoclonal antibodies that we used against the Delta strain particularly may not be effective against Omicron. And that really is a significant blow to our hopes of an early cure with Omicron. And that's precisely the reason why the authors of this publication, the COMET-ICE trial, used a new monoclonal antibody, sotrovimab, in patients with COVID-19. This, of course, was before the epidemic turned to the Omicron phase, but they used this monoclonal antibody, sotrovimab, in patients with COVID-19 to look at the outcomes. So the COMET-ICE trial evaluated the effect of the monoclonal antibody sotrovimab against COVID-19. As I mentioned before, the new variants may be resistant to conventional mAb therapy, particularly with the casirivimab, imdevimab combo that they use against the Delta strain. But sotrovimab targets a fairly conserved epitope that lies outside the rapidly changing receptor binding motif of the receptor binding domain. So many of these epitopes keep changing as the virus mutates, but this new monoclonal antibody sotrovimab is particularly targeted to the conserved epitope of the SARS-CoV-2 virus, where you don't normally expect mutations to happen. So that's the principle behind the use of sotrovimab. It targets parts of the virus, aspects of the virus in the receptor binding domain that is not prone to mutant variations. So this study was actually conducted, and they did an interim analysis among non-hospitalized patients with symptomatic COVID-19 who were less than 5 days after the onset of symptoms and who had risk factors for progression to severe disease. It was conducted across 37 trial sites in the US, in Canada, in Brazil, and in Spain. There were 291 patients in the sotrovimab arm, which used 500 milligrams of sotrovimab. And in the placebo arm, there were 292 subjects. The outcomes that they looked at was hospitalization or death within 29 days of administration of sotrovimab or placebo, as the case may be. 3 patients died. 3 patients were hospitalized or died in the sotrovimab arm, while 21 patients, 7%, had to be admitted to hospital or died in the placebo arm. So this difference of 3 patients versus 21 patients, either hospitalized or dead, was significantly different, 1% versus 7%, p-value of 0.002. So it goes to show that sotrovimab resulted in reduced hospitalization or death in the first 29 days among patients who were treated as outpatients. 5 patients required admission to the ICU, all in the placebo arm. There was only 1 mortality, this was in the placebo arm. Serious adverse events were less with sotrovimab. So in addition, patients who were treated with sotrovimab showed less use of respiratory support. They had less use of nasal cannulae, face mask, high flow nasal oxygen, non-invasive ventilation, invasive ventilation as well. And of course, as I mentioned, there was no mortality in the sotrovimab arm, while 1 patient died in the placebo arm. The requirement for ICU was entirely in the control arm. 5 patients required ICU admission, while none required ICU admission in the sotrovimab arm. So this study goes to show that the new monoclonal antibody, sotrovimab, may be significantly effective, particularly against the newer variants like Omicron, although this study, as I mentioned, did not specifically look at Omicron. The study was carried out much before the emergence of the Omicron variant. The next paper is regarding the high dose of Baclofen in the control of alcohol-related delirium. So we all face patients who are alcoholic in our ICUs, whom we often have to wrestle with and are hard to control. We try out different modalities of therapy, including benzodiazepines, haloperidol, sometimes propofol, and the list goes on. However, we often fail in adequate control of agitation and delirium in these patients. And that's why Baclofen in a high dose may be effective in alcohol-related delirium. And the authors ask the question as to whether it really results in a reduced incidence of delirium among patients who are alcoholic. So they studied mechanically ventilated patients from 18 French ICUs who had unhealthy alcohol use, according to definition, and they used Baclofen in a dose of 50 to 150 milligrams based on the renal function and compared it with placebo. And they used it for a maximum duration of 15 days, the dose being tapered off over a period of 3 to 6 days. So this study was Baclofen versus placebo in the control of alcohol-related delirium. Certainly a fairly new, innovative therapeutic modality in the treatment of alcohol-induced delirium. They looked at the incidence of at least one agitation-related event, and this was significantly higher with placebo compared to Baclofen. The incidence was 19.7% with Baclofen compared to 29.7% in the placebo arm, and the difference was statistically significant. So this study actually showed that Baclofen in a dose ranging from 50 to 150 milligrams might be effective in reducing the incidence of agitation-related events in patients who are alcohol abusers. They also looked at the duration of ventilation. In fact, the duration of ventilation was longer by 1 day in the Baclofen-treated group compared to the placebo group. So the median duration of ventilation was 9 days versus 8 days. ICU stay was also longer in Baclofen-treated patients, 14 days versus 11 days. The 28-day mortality was not different. The incidence of delayed awakening was also more with the use of Baclofen. So although Baclofen reduced the incidence of agitation, it prolonged the duration of ventilation by a median of 1 day, and also the duration of ICU stay by 3 days. However, this is one of those drugs which perhaps deserves more attention than we give it now, and may be a useful addition to our armamentarium in the treatment of patients with alcohol-induced delirium. We've come across many units, postoperative cardiac surgical units, that indulge extravagantly with the use of dobutamine as a means of inotropic support. Many are patients who are in postoperative cardiac surgical units who regularly get dobutamine, and free-flowing dobutamine is administered to many of these patients, even though they may have normal left ventricular function. Is this a particularly useful strategy? That's the question the authors of the Dobutax trial asked. So they asked the question, if the routine use of dobutamine in post-cardiac surgery patients is really useful in terms of improved clinical outcomes. Of course, the use of inotropes is by no means harmless, especially the fact that they can give rise to ventricular arrhythmias. They can predispose to the use of intra-aortic balloon pumps, and also can precipitate postoperative myocardial ischemia because they may increase the myocardial oxygen consumption. So that's why this question is relevant as to whether dobutamine to all versus a dobutamine sparing strategy is comparable in the clinical setting or not. So this was a single center randomized controlled trial. They studied patients who underwent coronary artery bypass graft under cardiopulmonary bypass. These were not patients who had surgery off pump. They were all on pump. And these were patients with preserved left ventricular ejection fraction with a EF of more than 50%. They were randomized in a 1-to-1 fashion. At the weaning of cardiopulmonary bypass, in the dobutamine group, all of these patients received a 5 microgram per kilogram per minute dose of dobutamine. And in the dobutamine sparing group, which is a control group, they received dobutamine only if the cardiac output was lower than 2.4 liters per minute per square meter body surface. And the dose of dobutamine was titrated to the hemodynamic status in both the groups. And it was weaned off based on the hemodynamic status of the patients. They looked at a composite outcome of 5 different parameters. These included ventricular or supraventricular arrhythmias, the incidence of acute myocardial infarction, the presence of a low cardiac output syndrome, the development of cardiogenic shock, or the development of stroke or transient ischemic attack. None of these outcomes individually were different between the two groups, nor was the composite outcome, which included all these outcomes. 31% in the dobutamine group versus 34% in the control groups. So neither the composite outcome nor the individual outcomes, individual components of the composite outcome were different between the dobutamine group versus the control group. They also found no difference in the length of ICU stay, the length of hospital stay, nor in the incidence of atrial fibrillation, heart failure, acute kidney injury, the requirement for renal replacement therapy, the presence of septic shock, or duration of mechanical ventilation of more than 48 hours. So this essentially shows that contrary to the practice in many cardiac surgical units, you need not necessarily put them all on dobutamine after postoperatively after cardiopulmonary, after coronary artery bypass grafting, be it under cardiopulmonary bypass or otherwise. Although this study focused on patients who had on-pump coronary artery bypass surgery. And finally, the ARREST trial. In fact, if you look at literature, this is an evolving field of expertise in which you use ECMO-facilitated CPR compared to standard advanced cardiac life support protocol in patients who present with out-of-hospital cardiac arrest. So there have been several observational studies in this regard, because we all know that the outcomes of out-of-hospital cardiac arrest remains extremely poor in spite of ACLS guideline-based support, even if it is initiated out of hospital with bystander CPR and continued with paramedics. The survival to hospital discharge is very poor, and it ranges anywhere between 0 to 2.8% in observational trials. And there have been several observational studies that have actually looked at ECMO-facilitated CPR among these patients. And the results have been promising. Some of these studies showing improved survival of up to 29 to 44% to hospital discharge. So it's an area of evolving research. And it's only appropriate that the authors of the ARREST trial performed the first randomized controlled trial that asks the question whether ECMO-facilitated CPR compared to conventional advanced cardiac life support protocol would change clinical outcomes. So the ARREST trial compared ECMO-facilitated CPR with just ACLS. It was a single-center phase 2 trial, and they included patients who were either in ventricular fibrillation or pulseless ventricular tachycardia following out-of-hospital cardiac arrest. And they chose patients who had no return of spontaneous circulation after 3 shocks. And even if they had 4 shocks or more, it was not an exclusion criterion, but they had to be in ventricular fibrillation or pulseless VT on arrival to the hospital. And the body habitus had to be such that it would support the use of a mechanical CPR device. And the estimated transfer time from the location to the emergency department had to be less than 30 minutes. So in the ECMO group, this was a very small study because they again halted the study in between. So there were only 15 patients in the ECMO group. And in this particular group, patients were immediately taken to the cath lab once they arrived at the hospital, and they assessed the patients. If there were 2 or more criteria of the following, they would cease resuscitation efforts, assume that the patient is not survivable. And these criteria included an end-tidal carbon dioxide level of less than 10, PO2 of less than 50, saturation of less than 85%, or a lactate of more than 18. So if 2 out of these criteria were present, they concluded that the patient was not survivable and they ceased all resuscitation effort. If they did not have these criteria, they would undergo veno-arterial ECMO. They would undergo coronary angiogram to look for possible blocks, coronary artery blocks, and address them appropriately. And they placed intra-aortic balloon pump in 40% of patients. So that was the protocol in the ECMO-facilitated CPR group. While in the control group, there were 14 patients, and they followed the ACLS guidelines as defined by the ACLS protocol. They continued the CPR efforts for 15 minutes after arrival to the emergency department, or for a minimum duration of 60 minutes from the time of call. Angiography is performed if a pulse was present on arrival to the emergency department, and the duration of ACLS after ED arrival was a mean of 28.5 minutes. So what did they find? They looked at the survival to hospital discharge as the primary outcome. 6 out of 14 of the ECMO-facilitated CPR group survived to hospital discharge, while only 1 out of 15 in the ACLS group survived to hospital discharge. And the lone survivor in the ACLS group also died at the 3-month assessment time. So the 6-month survival was 43%, 6 out of 14. All the patients who survived to hospital discharge in the ECMO-facilitated group survived to 6 months. That was 43%, 6 out of 14, while there were no survivors in the conventional ACLS group at 6 months. Besides, survivors in the ECMO group also had good functional outcomes at 6 months with a modified Rankin score 1.3 and a cerebral performance category score of 1.16. The duration of ICU stay of survivors in the ECMO group was 21.4 days, and that's the median duration of stay. And the duration of stay for hospital in survivors in the ECMO group was a median of 25.5 days in the quartile range of 11 to 40. So this study adds to our body of knowledge regarding the efficacy of ECMO-facilitated CPR compared to conventional CPR, and it might indeed be the technique to follow in the future among patients who suffer out-of-hospital cardiac arrest and perhaps even in-hospital cardiac arrest as well. Because if you carry out extracorporeal membrane oxygenation in an expeditious manner, they may have a better chance of survival and have a better chance of improved neurological outcomes. Thanks very much. Thank you.